know that complement proteins are produced during the immune response. The main ones that are produced in the early immune response are C proteins and interferons. C proteins are made by our liver. It's made anytime they're very sensitive. The liver will start to produce these proteins in the very early immune response. And interferons are proteins produced by cells that are infected with viruses. And those will allow those cells to be targeted for destruction. C-reactive proteins can basically set off a cascade of protein synthesis that can trigger cells to undergo apoptosis. They can also trigger and mark cells for destruction by natural killer cells by basically creating these surface proteins. And so C proteins made by the liver, interferons made by cells infected with viruses. Okay. So let's move into the next step, the adaptive immune response. So we've gone through the barriers, we've now gone through inflammation. We understand how we get heat, swelling, redness, and pain, as well as joint immobility, that there's vascular events, there's cellular events. We should know what some of the difference between chemotaxis and cytokines and how those differ from inflammatory mediators like histamines and leukotrienes, and some of our pain signaling molecules like not bradykinins, prostaglandins. So make sure you have a good sort of wrap on that. I highly recommend watching the overview, the Ninja Nerd overview, because it will break this down again for you. Okay. So in the adaptive immune response, we have two main cells located in the lymph node. And so if we go back to our whiteboard drawing, I have my neutrophils have dropped antigen particles into the lymphatic tissue. I have monocytes that have now become an antigen presenting cell, and they hold the coveted MHC2 molecule, which allows them to present the antigen on the surface of its cell membrane. Now we're entering to the lymph node space. And so in the lymph node space, inside of this lymph node, I'm going to have a couple different cells. I have a B cell, and then I have T cells, or specifically a CD4. CD4 cell. That CD4 cell plays a very important role here. So let's kind of go back to our PowerPoint slides. So if we look here at this drawing, you can see the CD4 cell, and then you can see the MHC particle presented on the surface of this very large cell here. So as that cell activates or moves into the lymph node with that MHC molecule, and then we have the particles of that antigen that have entered into that system, into that lymph node. Those inactive B cells, we call them naive. And once they react to those antigen particles that got dumped into there, they're going to bind to those particles are specifically formulated to bind to specific receptors, which are going to be a type of antibody that is a non-specific antibody that our B cells are just waiting for to bind to. And once they bind to, it's kind of like, I think of it like, the people in those movies that are sitting in the nuclear bunker and they like turn the key to arm the bomb. That's sort of what's happening here. These particles have armed the B cell. However, they cannot continue to mature to then get us to the point of making antibodies without the antigen presenting cell, which is the monocyte. And over here, this picture shows the MHC2 molecule activating the T helper cell. So it binds to a surface antigen on the T helper cell. That T helper cell, it also has, the monocyte has these little projections that's like squid-like arms, which also will bind to the T helper cell. So it has two phases of activation. T cells can also be, or these CD4 cells then are going to become an antigen presenting cell themselves. And those cells will carry the coveted MHC2 molecule because they are antigen presenting cells. to that immature B cell. So let's go back here. So I have immature B cell. I have antigen particles here. Antigen particles. Immature B cell will have a surface protein that can fit the specific antigen particle. This arms the B cell. Monocyte that has CD4 or MHC2 molecule on its surface binds to MHC2, binds to a molecule on this surface. Then we get an additional little spider-like projection which binds to another receptor. Doesn't really matter. This is just the process. It activates the T helper cell. The T helper cell now is an antigen presenting cell, and it's going to have a special receptor that's going to connect to the B cell. So we armed the B cell with the particles from the neutrophil. Now the monocyte is going to finish off the job by activating the CD4 cell. The CD4 cell activates the B cell, and then the B cell is going to differentiate into plasma cells. And these plasma cells now will start to make tons and tons of these. And these plasma cells will create antibodies. And they're going to create the antibodies utilizing the genetic code that was that it responded to by these particles that the neutrophils created. So you can see there are two very important steps here. There is the particles from the neutrophil activating the B cell and giving it the genetic material it needs to create the antibody. Then there's the CD4 T helper cell that finishes the activation of the B cell and helps the B cell mature. And that's triggered by the monocyte. So we have two very kind of key components here. And so when somebody has HIV, HIV is a virus that affects the T cell or CD4 cells. And when the CD4 cells, we don't have these special T cells because they get infected with a virus, we lose the ability to activate the B cell. I can still have neutrophils bring in the particles, arm the B cell, but I don't have this step anymore. And so I can't activate the B cell. And so I can never create specific antibodies to an infection. And this is why without antibody formation, we don't get over an infection. So if I had a simple bacterial pneumonia, let's say that, most people that get bacterial pneumonia survive it. It can make you pretty sick. But in someone with HIV, they get bacterial pneumonia. They can't create the antibodies needed to fight off that bacteria. And ultimately, they just have their inflammatory response, which the inflammatory response is only half of the equation. It can actually start to cause problems, right? When we have inflammation in the lungs and things like that, we start to have oxygenation, ventilation issues, and then people die of pneumonia. And so this is how immune dysfunction can cause a death from what's called an opportunistic infection. And that's basically in an immune suppressed person when we get an opportunistic infection, which is basically an infection that would normally be able to be fought off by a healthy immune system. But this is how HIV could affect T cells. So, anyway, if going back to we have our T cells, so we have our CD4 cell, it's activated, it's bound to the B cell. Now we get plasma cells. And these plasma cells are going to create antibodies. And we'll talk about the type of antibodies, but specifically there's two main responders. We get IgM and IgG antibodies. These are the first ones to respond. Oh, geez. IgG. IgM is the first one, and then IgG is the one that we get second. And they're kind of both made at the same time by these plasma cells and secreted into our circulation. So if you've ever gotten a blood test for, like if you've gotten a vaccine, let's say for hepatitis B, everyone in healthcare has to get that vaccine series. And you get the vaccine and you have what's called acquired immunity. So you've acquired these IgG antibodies and IgM. IgM antibodies tend to fall out of circulation very quickly. They don't stick around, where IgG antibodies stick around for a long time. So if you go and draw a titer, what's called, to see if you've gotten that vaccine or if you've ever had that virus, they're testing for those IgG antibodies. That's what they're measuring. Just to put that into some real world perspective. So once we create these antibodies, we'll go over what the antibodies do here in a little bit. But I want to go back to the slides first. Okay. The other cell that can get activated by the monocytes is the CD8 cells. And then what happens is they get brought the part of the antigen, and those can activate what's called cell-mediated immunity, which does not require antibodies. Those cells will go out and start to attack the specific antigens that they're sensitized to. And those T cells can become sensitized to many different antigens and start to go have an inflammatory response. The utilization of the CD8 cells is a slower response. And so an example of this type of immune response, if you've ever had poison oak, you've had your T cells get sensitized to the the oil from the poison ivy plant or poison oak plant, and that causes a delayed cell reaction, and that's specific to T cell sensitization. So that's your T cells. This is an example of those T helper cells activating that B cell, and that B cell starting to activate and proliferate other B cells. It does that by producing special cytokines themselves and releasing them. But anyway, let's go here. Okay, so B cells, we talked about them a lot already. They are produced mature in the bone marrow, but they don't mature or become activated until they are exposed into a pathogen or antigen. They have a surface antibody called IgD, which is going to bind to non-specifically to particles released by those neutrophils, and then they get assisted by the CD4 cells. You don't need to memorize what chemicals they release. They release some chemicals that basically causes the proliferation of the B cells into those plasma cells. The plasma cells then start to create antibodies. They also will stick around as memory cells, and those memory cells then will be primed in case you get exposed to that again. Those memory cells can quickly produce antibodies again for that. So even if the antibody levels drop, you may have beat plasma cells that are memory cells. So the second time you get sick, even if you don't have antibodies still floating around for that virus or whatever, your memory B cells will be able to quickly create new antibodies, so you don't get as sick the second time. These are antibodies. We talked a lot about what antibodies do, and let's look at the type of antibodies there are. So you have 5 antibodies. The two on the left, IgM and IgG, are the primary ones we make in response to an antigen. You can see the IgM is very large. It is 5 proteins stuck together, and those proteins will bind to things and basically cause destruction through triggering a process called agglutination, where they cause all these things to stick together and clump, and these cells will undergo a destruction. And our immune system, other immune cells will, once there's IgM antibodies bound to them, will trigger the action of those immune cells to destroy the infected cells. So the other things that it does is it does not cross the placental barrier. So I can't pass these on from mom to baby, right? So baby can't get immunity from mom through IgM antibodies. They have to be IgG because IgG is small enough to cross that barrier. And so IgG antibodies also will cause a process called agglutination, which is where they will lump all these things together. And they will also trigger cells to rapidly destroy the bacteria or whatever it is that is now that antigen now is bound to that IgG or IgG antibody. Yeah. those are able to cross that blood-brain barrier and the placental barrier and things like that. And those stick around a lot longer. So they're kind of the second formed. Initially is going to be IgM, and then IgG antibodies are going to be the second formation. The third type of antibody is formed during a secretion or into secretions, and we find special these cells, these plasma cells, these B cells that create these antibodies are primarily located anywhere that we're producing secretions, producing mucus cell near mucus cells in the respiratory tract, in the near the lacrimal ducts, tear ducts, salivary glands. We produce specific antibodies that are found in secretions to basically respond to different pathogens. And some of this we get as early as being born. These are passed in through from mom to baby during in the birth canal, for example. Then the next antibody is called an IgE antibody. This antibody is present not commonly uh, elevated during normal infections, but it is for some reason in some people elevated and when they are exposed to an antigen. And people that form IgE antibodies in response to an antigen will have allergic reactions to those antigens. And where these antibodies are formed, in particular, are the respiratory mucosa and the GI tract mucosa. And allergic reactions, one key thing to note is we often are taught to look for urticaria, hives, and swelling of the airways as their first signs of an anaphylactic reaction. But actually, GI distress can be one of the first early indicators of an anaphylactic reaction because these IgE antibodies will bind to those eosinophils and basophils, and then that cross links to all the mast cells and causes mass degranulation of mast cells, releasing tons of histamine and leukotrienes, which cause increased capillary permeability and swelling, and all sorts of those bad things we see in anaphylaxis. So, if your patient or you're ever out hiking with somebody or something, they get stung by a bee and immediately develop GI distress, that's an indication of anaphylaxis. So usually we think of anaphylaxis as two or more body systems or organ systems, but GI upset and hives or swelling of the throat or any of those things or wheezing, um, that's automatically anaphylaxis, and we want to treat that with epinephrine. So IgE antibodies elevated during anaphylactic reactions. IgD, these are found on the B cells. They are not really play much of a role in the immune response other than the activation of the B cell. Okay, this is how cells are in these like ductal areas in the mucosal membranes or in the not in the GI tract or these areas of the tear ducts. These are areas where these, in the specific lymphatic tissue, these B cells will produce IgA antibodies, which will find their way into secretions in response or exposures to certain things. And these will help us fight off pathogens. And, this is, if you've ever wondered why, like if you go to another country where people aren't getting necessarily like they eat the food there and drink the water all the time and they don't get sick, and then you have ice in your drink and you get GI upset. Well, some of that can be exposure to different pathogens that are found in drinking water or in food or things in different places that we just aren't exposed to, and so we don't have these IgA antibodies within our mucosal membranes and things like that that can help fight just keep those pathogens from creating an inflammatory response. And so if it's your first time being exposed to them, guess what? You get sick. Okay, so that kind of covers that adaptive immune response. And then we'll talk a little bit about cell mediated. And remember, in the activation of the B cells, we can also activate a different type of CD cell. Remember, the other type is our CD8 cell. So in my lymph node, and then I have this CD8 cell. And this is the cytotoxic T cell. So CD8 T cell, this cell can get activated in addition to the CD4 cell. We can activate the CD8 cell in response to an antigen. And some antigens go down this pathway more specifically and evade the classic pathway of antibody production. And that example of that is poison oak. So if our cells are exposed to those, so our CD8 cells get sensitized to some sort of antigen, they can then go out into the bloodstream. And what they do is they will target whatever thing they're sensitized to. They're going to attack and cause destruction of the cell membrane and cell mediated actions. And so cell mediated immunity involves two main cells. We have the T cells, the CD8 cells, natural killers, and the natural killer cells. T helper cells differentiate down that different pathway. Remember, into those, we have either the CD4 or the CD8 cells. Those CD8 cells will specifically react to, once they're sensitized to whatever antigen they're sensitized to, but they're one main thing they play a role in is fighting viruses and cancer or malignancies. And so they are very important in the process of killing that, and they promote apoptosis or self-destruction, and then they perforate the cell membrane specifically. And the natural killer cells also play a role in cell-mediated immunity, fighting off cancerous cells and viruses as well. They specifically, though, once IgG antibodies get formed, they will bind to cells that have IgG antibodies found, and they will quickly clear or eliminate bacteria or any antigen that we have those specific IgG antibodies for. So once we have IgG antibodies in our circulation, where we've been exposed to something where we have immunity to it, now our natural killer cells can recognize it immediately and destroy it before it causes inflammation. So this is how if you are exposed to whatever it is once and you create IgG antibodies, let's say you got really sick that first time you got whatever virus, but then you've had that virus, then your IgG antibodies are higher in concentration for a period of time. You are immune to that. You get exposed to that same virus again, you're not going to have the same reaction because the natural killer cells will destroy with those whatever those IgG antibodies bind to. So that's one very important way that natural killer cells work in those secondary exposures, and that's all part of our cell mediated. We call cell mediated, and for test taking, that involves either cytotoxic T cells and natural killer cells being activated to destroy specific antigens. Okay, so what we've been talking about is acquiring immunity in what's called an active form. So if I get immunity and I have an immune response, let's say you get exposed to a pathogen, you get sick, you have an immune response, you make antibodies, you get better because you make those antibodies, and then now your immune system can fully destroy and clear whatever is causing that infection. That is called active immunity. There are two types of active immunity. We could have acquired active immunity or artificial, or basically, or like a natural active immunity. So I get sick or exposed to the virus or some sort of illness, and I'm going to create antibodies. That's active. And then I can have that artificial active immunity where I get like a reaction to a vaccine. It's not necessarily artificial. It's rather you're still getting exposed to that through an outside source. Then we have passive immunity, which is now where I don't have to have the immune response. I can get this immunity through from another source. So childbirth, going through the birth canal, getting exposed to IgA secretions, breastfeeding, getting IgA antibodies through breast milk. These are all examples of passive immunity that does not require us to get any sort of illness or symptoms. And then the other way we can do this is by actually giving somebody antibodies to something. And we use this all the time. If you've ever like seen a patient that's had a rattlesnake bite, for example, and we give them antivenom. That antivenom is an immunoglobulin made in response to that specific venom, and we're basically giving the IgG antibody for that venom. So that's an example of giving somebody the immunity to something. Um, Immunoglobulin therapy is quite interesting of how we actually create them. Um, anyway, it's quite an interesting process. I recommend researching more into it if you're interested in the immune system. Okay, so those are the two ways we can acquire something, and that's passive acquired or active acquired immunity. Let's talk about the different hypersensitivity reactions. This is pretty important to understand because we're going to talk about blood transfusion reactions this week. And we're also talking about anaphylaxis, treating that a lot. This is something two areas where we deal with immune responses quite a bit. So, as blood products become more standard of care in pre hospital, we do need to be quite cognizant of blood transfusion reactions. And one of the main types we worry about is incompatibility, and that is a type of hypersensitivity. And we'll talk about that. And the other major thing we talk about a lot is a treatment of allergic reactions, which we've already broken down the IgG cross-linking and the degranulation from the IgG antibody and the antigen to the mast cell and the basophils helping that. Anyway, we've sort of looked at this process a lot. And we treat anaphylactic reactions, so we should understand how they work. The other types we look at here are going to be the delayed or cell mediated, and then also the histo immune complex, where we get basically antibody tissue reactions, and these can be autoimmune diseases like rheumatoid arthritis and things like that. So the first type is type 1 hypersensitivity, and this is going to be allergic reactions and specifically IgE antibody mediated. And so anytime we create IgE antibodies to a pathogen, we can have an allergic reaction to it. And this generally, these create a large systemic response. They can be responsible for localized allergic reactions, but if you have a local allergy to, let's say you get stung by a bee and you have a very exaggerated response, like you get this kind of nasty rash all the way up your arm, it gets very swollen, but maybe you don't have any airway involvement, any GI upset, any wheezing or anything, any cardiovascular effects like tachycardia, anxiety, things like that. Uh, it's not an anaphylactic reaction, it's a localized allergic reaction, but that doesn't necessarily mean the next time you get stung by a bee, you might actually have that more systemic effect. So, IgE mediated is going to cause lots and lots of histamine release and leukotriene release from those mast cells because it basically the IgE antibody hypersensitizes the mast cells to the antigen. And that IgE antibody will bind to other white blood cells and bind to the pathogen and cause a super like a super degranulation of lots and excessive amounts of your mast cells, and so you get lots and lots of histamine. Okay, the next type is going to be the cell mediated or or IgG mediated cytotoxic hypersensitivity. So IgG mediated, this is now where we can have IgG antibodies that we have present causing a hypersensitivity. And this is found primarily, the best way to describe this is going to be our blood incompatibility. So if I am type B blood, I will automatically have type A anti A antibodies. Talk about, I'm not going to have uh, anti-O because anti-O is doesn't you're not going you don't form antibodies to O, but you form antibodies to the opposite type that you have. And so if I have type A antibodies or anti-A IgG antibodies and I give that person A type blood, that IgG antibody will respond to the type A antigen and cause that agglutination. So you get clumping of blood cells and starting to rupture the blood cells, and you get hemolysis and all sorts of stuff. So this is IgG mediated cytotoxic hypersensitivity. The next is called the immune complex. And this can happen where you get an immune uh, antigen that binds to a free floating um, antibody specifically for that. So, and then this antibody can implant itself into tissues. Let's say it gets deposited into the joint spaces. And that antibody then is left in there, and our immune system recognizes that antibody and that antigen as needing to be attacked. So, our natural killer cells will start to attack our own tissue cells. And this can happen in all sorts of cells. In all sorts of types of diseases. So we talk a little bit about rheumatoid arthritis, but also things like glomerular nephritis, which is where the kidney capsule gets attacked. And this can happen after certain bacterial infections like strep. There is a specific strain of Streptococcus bacteria that can trigger this autoimmune reaction by creating this histocomplex or this immune complex with the antigen from the strep, and that can bind into your tissues like your heart valves, your kidneys, your other in the connective tissues, and cause all sorts of problems. And so people that have lifelong chronic inflammation from this can be very debilitating and it can also like with people with lupus, people with rheumatoid arthritis. This is all immune complex. And then the last is like that poison oak reaction. And this is where your T cells, your cytotoxic T cells get activated. And that activation of the cytotoxic T cells causes some sort of sensitization to something. And one great example of this is poison oak. But other types of things like contact dermatitis, which is like if you have ever had like a piece of jewelry or a bed sheet or some sort of like you've used some kind of soap in your or laundry detergent that caused you to have a skin reaction. It's actually not a histamine reaction. That is usually some type of contact dermatitis, which is a T cell reaction. And so probably why if you took Benadryl or something, it didn't really help a whole lot. So anyway, these are other types of autoimmune diseases can also be attributed to this type of reaction. Diabetes, type 1 diabetes, which is can affect the beta cells in the pancreas. Other types of things, again, like multiple sclerosis, rheumatoid arthritis, again, can also have an aspect of cell mediated immunity as well. So these are the 4 types of hypersensitivity. I would be very, very familiar with type 1 and type 2. So anaphylaxis and allergic reactions, and specifically as we talk about blood transfusion reactions, type incompatibility. I would be very familiar with those for testing. The other 2 is nice to know. These 2 for testing, definitely know these 2. Okay, that's the end. Please watch the video. This was just a very brief overview of the immune system. So watch the Ninja Nerd, read the chapter, and let me know if you have any questions.